Welcome everybody to the Random Anesthesia Topic podcast. In this episode, we have Dr. Natasha Bartel from King's Animal Hospital in Ontario. We have Dr. Ryan Bailey that works with us at Safe Pet Anesthesia. And I'm Dr. Gianluca Bini, CEO and co-founder of Safe Pet Anesthesia, a training and teleconsulting company. And I'm also an assistant professor of anesthesia and analgesia at Oklahoma State University. Let's get started. All right, so tonight we have our guest, Dr. Alvarez. She's a diplomate in sports medicine and rehabilitation. She's also certified in veterinary acupuncture, and she currently works at the Schwarzman Animal Medical Center in New York. Thank you so much for being here with us tonight. I think we have a few questions for you, and you feel free to ask us any anesthesia-related questions, or I guess, analgesia as well. Everybody forgets that we are like anesthesia and analgesia, but people forget about that.
That's good. I didn't know I could ask you questions.
You can. Yeah, this is free for all.
Awesome.
So I have a first question for you. A lot of what you guys do I think you guys do an amazing job with the rehab with, for our small animal patients. I think it's kind of rare to have somebody that does, do you have more people that do like small animal or large animal and do your college? Is it like...
That's a good question. Yeah. So the American College of Veterinary Sports Medicine and Rehabilitation has two colleges, the Canine College and the Equine. Well, it's one college, but it's similar to the ACVS that has large animal and small animal. We have canine and equine. And I will say that I definitely treat cats and other small species, but the college is specific for canine, and same for the equine. I think a lot of my equine colleagues will treat livestock and other large animals, but it's only equine. So unlike the surgery college, we don't treat all the small species and all the large species. It's focused on canine and equine. And the reason for that is the college first formed to help performance athletes. And because, cows and sheep are not athletes, and because cats are not athletes, then that's why specific canine and equine.
Okay. That's really, really cool. I always feel like a lot of people that are not into veterinary medicine, they don't even know that there is such specializations, right? And we have a few listeners that actually, I think, they're not into the vet med space.
Yeah, and we could talk about that because it's a question that I get is like, so what athletes are you treating? Like they don't realize that dogs are athletes. And interestingly, when the college was provisionally approved by the AVMA in 2012, and then we received the final approval in 2018. So the college has been approved accreditation from the AVMA since 2018. It's the newest specialty in veterinary medicine. And so it's definitely emerging area of specialty. And I think a lot of veterinarians don't know what we do. And so certainly the public doesn't know what we do, especially because there are a lot of certification programs. You mentioned that I'm certified in acupuncture. I see them as continuing education programs where you gain advanced training in something specific, but there's no requirement for that certification for ongoing training. So I got certified in acupuncture, I think it was 2006 or 2007. And I don't need to do anything to still put the CVA after my name, which is different, of course, as you know, being board certified anesthesiologist and any other board specialty, you're required to complete training, whether that's giving lectures, publishing, educational thing, or actually sitting for the boards again in order to maintain your diplomat status. There are certifications in rehabilitation, which I think is confusing for the public and veterinarians because people will say that they're certified in canine rehabilitation, which I have that certification. I had that before the board specialty was available. But I don't even use those letters anymore because, of course, my board specialty is really, I think, what allows me to be a specialist. And of course, do a lot to keep up that level of specialty. The certification is fantastic. And I think there's a really great rehabilitation therapists who've completed that advanced training, but of course it's nothing in comparison to a 3-year residency sitting for a board examination. And to answer your listeners' questions about, what athletes do I treat, I liken it to maybe you, Gianluca, maybe, you're not an athlete, but you could still injure your ACL and you will see a sports medicine specialist.
Yeah,
So
that's true.
you don't have to be an athlete to see a sports medicine specialist. We specialize in the treatment of soft tissue injuries and for the most part pursue non-invasive therapies. Of course, we work closely with surgeons. So if that musculoskeletal injury is such that it's not amenable to rehabilitation, or we tried rehabilitation, we're not getting the results we want, we would of course send them to surgery. But usually a first step is we do strengthening, a lot of pain management. We can talk about that. I know that's your specialty. We were just saying this, that anesthesia, everybody thinks of the anesthesiologist. You're in the operating room and you're giving a lot of advice on how to manage the anesthesia. There's a pain aspect to that as well. We have anesthesiologists at AMC, and they manage acute pain in the OR and postoperative pain. I don't hardly ever get that. I do chronic pain management, outpatient care, oral analgesics.
Yeah. No, that's all really. I think it's really cool, and it's one of those things that again, the public definitely it's totally oblivious to, right? Like they don't know this. And we get asked a lot of, like, sometimes we do get asked those chronic pain questions, and we definitely focus way more on the acute pain side, right? Like even the residency. Now we do have, I think, a fellowship in pain management or something like that, that was recently
Oh, that's
established,
cool.
but it's not something that a lot of people are into. Most of us are more hired for, um, you know, perioperative
Yep.
Yeah.
management.
Injectable drugs.
Yeah.
Yes.
Yeah. Yeah.
Yeah.
Yeah, that's
Um,
I get afraid with the injectables. I'm all about oral drugs, so those would be my questions for you. Is like, what do I do? And we see a lot of senior dogs that we do procedures on. So but besides the rehabilitation aspect of it, we will do some minor interventions like joint injections, for example. We do tendon injections as well, and we'll need to sedate patients. And so at some point, maybe I can pick your brain about your favorite safe ways of sedating a patient.
for sure. So, I think when we go into the chronic pain, because this is where we overlap a little bit, right? When we go into the chronic pains kind of things, I think there is a lot of new options that came into the market recently, right? Or at least in the last couple of years. You know, do you, some people do this kind of like subcutaneous ketamine injection, right? Like every 2 weeks, every 3 weeks. Is that something that you guys do? What kind of results have you, and if you do, what kind of results have you been having with that?
Yeah, I love subcutaneous. So I do some injectables. um, I use it. I should preface by saying that it's not the first thing I reach for chronic pain. These would definitely be refractory cases. These are cases where we're worried about central sensitization and there's difficulty in managing the pet on the oral analgesics. I love ketamine as a drug. I think it's quite safe. It's been around for such a long time. And I love the resurgence that we've seen in ketamine as a drug. In particular, the studies on the human side for managing refractory depression. And, it really, I think, has uses far beyond the perioperative. I think that we before, and maybe the other thing was recreational, right? That's the other thing. I'll get clients are like, "Oh, you mean that ketamine from the '70s?" But so yes, we've used subQ ketamine. I prefer to admit the patient for CRI of ketamine. I think that is important to have the best utility of then the less frequent injection. Not always. Sometimes patients are too anxious, or for various reasons, we can't do that CRI, which we'll just do for 6-8 hours. It doesn't even have to be a full 24 hours. And then I typically do twice weekly injections to begin. So they're responding to that and taper off to effect. Most of them, they're getting about, I would say, once weekly for a month. The goal is not that they stay on these sub-Q ketamine forever. It's more to control that refractory pain state, that it's more manageable. So it's really, I think, to get them into a place where we can do maintenance more easily, because I think it acts more quickly than some of our oral medications. But yeah, especially for the sexually sensitized patient, we love subketamine.
That's really cool. I think so. Looking online, when people ask on forums, or there is anesthesia Facebook groups and whatnot, I think a lot of people don't do, like, they just do every 2 weeks, without, the protocol you described, quote unquote, sort of like looked something like you do a loading
Yeah,
dose, quote unquote, right, of ketamine, and then you
yeah,
just taper them off slowly. And
correct.
actually, it's, more, I don't want to say it's more aggressive, but like, it's, there is a higher, higher frequency, even as you right at the beginning, rather than, somebody that do, you know, zero point 0.5 mg per kg subcute every 2 weeks. So
Yeah,
I think your protocol makes, I think, a lot of sense, but I don't think that everybody out there is doing something as what you guys are doing. It's like, I think that the average practitioner or the average clinic
yeah.
out there, it's doing this extremely spaced out, very low dose.
Yeah, I would think that, especially if that's how you start, I just don't know how effective that would be. I have heard practitioners say that they start with the subQ ketamine when they are starting oral amantadine, which is also an NMDA inhibitor. I don't know. I'd want to see a study to show that they have the same mechanism of action, but they're different drugs. So I don't know that when you start amantadine, if you then give subQ injection of ketamine, that somehow the amantadine.
I've been asked that
The,
exact same question, and I've given the exact same answer. I'm like, why would you do that? I mean, I guess,
yeah, like
but they're different drugs. One's an antiviral that also has an NDA, and one is like so I'm like, I mean,
yeah,
it's probably not going to harm the patient, but like, I don't think it's going to work the way.
yeah.
Like, I feel like,
I
yeah,
think people think like, oh, same
yep,
target, like then, but
yeah,
I don't think they're the same. Well, we know they're not the same drug, so yeah, I use it, as I said. I think that that's for the more severe refractory pain. You really need to interject in a big way. You
Yeah.
get the pain under control, and then you can rely on your orals, which oftentimes does involve amantadine. So amantadine is a drug for central sensitization, and it does take a bit of time to kick in. But I'm not using them interchangeably. It's that you need both, actually, and the amantadine would be more maintenance, whereas the injectable ketamine would be more for that intervention that needs to be a little bit more aggressive.
Yeah. I like your protocol and how you like. I
Well,
think it
thank
makes
you. I'm
makes way
glad you
more
approve.
sense.
It means a lot coming from two anesthesiologists.
No, I think it makes sense. I think it's, if you're gonna see an effect, you're probably gonna see it with something like that, rather than, the random super spaced out tiny dose,
Yeah, yeah,
ketamine injections. But yeah, and it's sad that there is no study on this, right? Like, I wish there was some more literature out there, but it's everything that's pain related in vet med. It's, it's really hard to study, right? Our patients don't speak, they can't really tell us how they feel. We have, unfortunately, a huge problem with that. Do you do you feel like one course is enough for these patients, or do you think do you repeat the same protocol multiple times during the year? How do you do that?
yeah. That's a good question. I'm not doing it that often. I would say majority of patients I've done it in, we just did it the one time, because these are usually new patients who we've been treating, say, for a month. and then we do a recheck, and they're still, I usually CBPI, the case brief inventory. We do it for every initial consultation, and we use that as a guidance of how effective our therapies are for pain intervention. And if we're not meeting our goals to reduce that pain severity score, the pain interference score, then that's usually also like, okay, well, I think we need to step it up. Let's do something else. I guess I did have one patient, it had a contracture. And so ideally what we want to do is have that intervention that's more aggressive, and then you go to an oral maintenance that will manage that pain long term. But there are patients that have repeated inflicting pain. You may need to repeat the course. I would say that's a minority. If I think about, let's say, an advanced OA case, they shouldn't need more than one intervention. I think if you're doing a good job of your chronic pain management. So I would say it really depends on the individual. And the only cases where we would repeat a course of injectable ketamine is if there's continuing source of pain that we can't manage, which I would say is pretty.
That's cool. Do you like? And this came up because I was chatting with somebody else that does sports medicine. Do you ever do like steroids, lumbosacral injections, stuff like that?
Yeah, we had a patient today that has lumbar sacral disease and has had chronic IVDD. And it's an older patient. And so this came up about sedation and how do we do that safely in a 14-year-old dog who's already ataxic. But yes, we've actually had great success with epidurals. We typically do, we combine usually an opioid, a steroid, and a local anesthetic. And it can be, it could be like game changer for some of these dogs. I mean, they just go from they can't get up on anything. Owners complain like they can't get up on the bed anymore. They can't get into the car, and the epidural, and the next day they're just like brand new. So you can get really lovely efficacy. And I find it's a very straightforward procedure. It really doesn't take long at all. Very well tolerated. Again, it's not the first thing that I reach for. These are, again, cases where, okay, we did, for the LS cases, I really like a combination of acupuncture. I love shockwave therapy. That's given us really nice results together with strengthening. And if that combination, which most of my patients will respond to, if I'm not getting the efficacy that we expect, then I do offer epidural. That would be the next phase.
That's cool. So actually, the conversation I was having was about lumbosacral injections, but they were asking about the specific needle, right? So like some, and I don't know if if you're aware of this or not, but there is several different like epidural needles or spinal needles, right? And so somebody, they were asking about like the different like epidural needles, and I think what kind of needle do you use? Do you use a normal spinal needle or?
I typically do, but it's interesting. The last one we had, the anesthesiologist was like, "Oh, there's this other kind of needle, and you don't do the hanging drop. We usually do the hanging drop technique, but they had another one that I don't even remember, but it was a different kind of needle, and it's not a hanging drop. She liked it better, but that's
Mhm.
I'm a little traditional, just the standard epidural needle.
So what do you use for your epidurals, Ryan? Do you use a spinal or a TUI needle?
I actually converted to nerve stimulator.
Yeah, that's what she used, the nerve
Yeah,
stimulator.
because
Yeah.
it just, with where I was practicing, it just gave everyone in the room the ability to kind of witness success or failure. And like, there's reasons the hanging drop doesn't work. Like, if you go through your needle track too many times, you can get
You
like a
don't get
false
the
positive, and
negative
then
pressure. Yeah.
it becomes like there can just sometimes be like, to not put it bluntly, like ego that gets in the way, and then people say, "Oh, I'm in." It's like, yeah, they're paying three
How do
hundred
you know?
dollars for this, and we're relying on this to be the like main analgesic, and I'm not gonna like. I don't want to like. I want people to learn, and I want them to grow and gain confidence, but I also want the patient to receive what they're supposed to receive. So I switched to the nerve stimulator and never looked back. And There are a couple issues. You don't get that hanging drops. Like if that is a skill you learn, it probably does get rusty. And then if you ever place an epidural catheter, you definitely cannot place it through the nerve stimulator needle. So then you're trying with a TUI, which is a little bit different. Yeah, that's like the big disadvantage to that. But for like, I've placed one epidural catheter in my lifetime, and I suspect that's probably going to stay pretty low, no
Yeah.
matter what I end up doing in my life. So
Yeah, definitely you're not placing one with us.
yeah, they're not even that common. And I don't know about AMC, but like in the places I've practiced, they're
No, we don't do catheters. No.
one a year maybe, like in clinical practice. Like, yeah. So
Yeah, they're kind of rare. Yeah, I'm more used to
Yeah,
like
but the
two.
only time I would think if there was a spinal tumor where you have ongoing pain where you would want to have
yeah,
access.
Maybe, yeah.
in humans, it's like it's like so many of them are done epidurally, like or like catheterized. Like that's the way they do a
Yeah.
lot of the epidurals nowadays. Like
Oh,
it's single shots are rarer for them than the catheter
oh,
placement.
interesting.
Yeah,
Okay.
it's a weird world.
Yeah.
Yeah.
Yeah,
Oh.
even when you're, in pregnant women,
Yep.
that's they're all catheterized,
Yeah.
so that
Mm.
they give a continuous infusion to
Yes,
the
you know what? Now I'm like, well, I mean, my youngest child is 13 years old, so that's 13 years ago. But no, that's right. I remember that they would like continue to give you as needed. Yeah, yeah.
Yeah, yeah. And so for those, you need to use a TUI needle. I usually use a TUI just because I learned that way, and I'm like, it has a curved tip, which it
You got to
gives you a
hold
little
it.
bit better feeling of, yep, you just put it in like this, which is pretty cool. But yeah, I mean, it's interesting. Some people use ultrasound nowadays, but I, you
For
know,
like the Frenchies, maybe like the patients who have really abnormal spines. I think that does
Yeah,
have
if
its
you have
place
like
just
a
to help
bridging
you locate.
spondylosis
You
or
know?
something. Yeah.
Yeah.
Mm-hmm.
yeah, those
Yeah.
patients probably then it makes more sense.
Mm-hmm.
But sometimes it's cumbersome, right? Like, having yeah.
I
Okay,
also think
that's
that veterinarians are not as good about sterility. And when there's an ultrasound probe there, I just think it dirties the.
Yep.
yeah.
Yeah.
Um, I have a question from my own personal experience. So I am one of those athletes who went to like, my own rehabilitation because I had like an injury was preventing me from running and this and that. And no matter when I went, the whole place was slammed. The human rehab centers were slammed, and you had
Yeah.
who's just like rehabbing a soft tissue injury. You had my upstairs neighbor actually who was coming off. He showed up. I was like, "Why are you here?" And he was like, "Oh, I he tore his Achilles and had surgery." There were people who were like prehabbing, I guess, like
It,
prehabilitating before they go to surgery, or to like potentially try to avoid surgery, even though it's probably in the cards. And I feel like just personally, and that's why I want to ask you the question is like, I feel like that is an underutilized, like the whole rehabilitation arm is just underutilized compared to the way I see it in human medicine. Like
oh, you're
when I did my rotations,
preaching to the choir. I couldn't agree more.
yeah, like when I went to the human hospitals, they did blocks for the humans, but they wanted you to be up and mobile so that they could start rehabilitating you within the next day of anesthesia. That was their goal for their
Including
ortho
spinal
stuff.
surgery. You know,
Yeah,
you have spinal surgery and you have the PT working on you and you have to be up and moving. But we put ours in a cage, like don't move for
yeah,
4 weeks. Yeah, very different approach. Yeah. I
yeah.
Yeah.
think
So I
it's an
guess my question
evolution and yeah.
is like, should we be doing more? Is there more advocacy? Like, because we're the
Yeah.
ones in there right away getting the pain management going, but then I feel like I don't know, there's a slow adopting of getting these patients to you guys sooner,
Yes. Yeah, I absolutely agree. It is very underutilized. The other thing, I can just speak from my own experience at AMC. Our TPLOs, they're coming out of the OR and we are working on them immediately. So we do intervene with the TPLOs. It's actually included in their surgery package. The
Oh, nice.
rehabilitation is included. Yep. And then the next day we work with them again, and then we generate a home discharge instruction that has exercises that they should begin right away. And then 2 weeks postoperative, they can begin a formal rehabilitation program. I wish every patient was like that. That's the one that I think we tackled correctly, because other, let's say, orthopedic fractures, they don't have that plan. So then we rely on the surgeon to make the recommendation, then the owner has to approve it, and then there's a conversation, well, is it necessary? And they're like, well, it's not necessary. I want to say it's necessary. But
Yeah.
and then it becomes about cost, and that's why we just bundled it for the TPLOs, because I don't want people to have that conversation. Like, yes, it's important. Like, it's not necessary, but it's important. It should help your recovery. But you know how it is in veterinary medicine. Everything is about the estimate and the money. And
That's
you end
true.
up,
That's
it's
true.
like, I feel like a used car salesman when you're like, well, you could do this. We could do that.
Yeah.
Whereas in human medicine, you don't have a choice. This is what the doctor recommends, and that's what you do.
Yeah.
But yeah, I love prehabbing. We definitely have that for a lot of our patellar luxations. That's a common patient for prehab, where the owners will come and they'll say they saw their vet and they're recommending surgery, but then maybe you can try rehab first. And a lot of them, I will say, really, I've been even surprised. Usually I think about the grade 3 patellar luxations. They don't, they're really, you're lucky if they're going to get better with rehab, because they're already wanting to be out. And those are the ones where I don't give owners the greatest hopes that we can stay out of the OR. But I've been pleasantly surprised. We had some grade 3s that we got to stabilize to grade 2, and we're able to avoid surgery. And definitely a lot, I would say probably a majority of the grade 2s that come to us, we can keep them out of the OR. And it's just simple anatomy. The quadriceps ends in the patellar tendon. If you can do really good quadriceps strengthening, you can keep that patella in place. It works. It's a really very straightforward rehabilitation approach of strengthening that really works to stabilize that patella. And we've had it also for hips, where they're a potential candidate for total hip replacement. And the surgeon will say, well, why don't we try rehab first? And then if that's not bringing the results that you want, then we can do the total hip replacement. We've had several patients, again, where they did so well. The surgeon, it's funny, I was the one that was asking for surgery because the hips were so horrible. But then the surgeon said, well, they look so good, I don't need to do surgery anymore. I'm like, no, I can make them look worse. Like, please replace their hips, because their hips are in such bad shape. But yeah, it's wonderful to do that. But then the other thing I will say is, I think a lot of people don't realize that rehab touches practically every other specialty. There is, because the focus that we have is twofold. One is pain management, definitely, but the other is improving function. And when you broaden it like that and you think about, well, what patients have decreased function? Well, it's like every sick patient. I mean, everybody that has been hospitalized for, it doesn't have to be musculoskeletal. We treat a lot of patients that are internal medicine patients or critical care patients that, because of a severe illness, develop difficulty moving or have pain management issues from their severe illness. But yeah, we interact with internal medicine. We interact with exotics, definitely, critical care, as well as dermatology, even oncology for sure, the oncology patients. I will say the one specialty we don't interact with is ophthalmology. We don't rehab the eye. But other than that, like, I've done rehab for jaws, like from dentistry. Wow. We've had a lot of, they had like a partial mandibulectomy, or, had other chewing problems, and we need to strengthen like our muscle. And anyway, we really can rehab practically anything in the body. And of course we see it on the human side, and they're specialized. So it's also, the history of veterinary medicine is, suspect over time we'll get more specialized, but right now we rehab everything. It's just not specific. They have, for example, they have respiratory rehab in the ICU for humans. Like if you're having trouble, and there's all these techniques that help with moving fluid so that you can evacuate that fluid. And they've shown that the hospitalization of those respiratory patients is shortened if they're doing respiratory rehab. So it's really fascinating.
That's cool.
never ending the opportunities. I'm so excited to be in this specialty because I see so many opportunities. We have to study a lot. There's a big gap in knowledge. There's a lot of things that I would like to contribute to, including in the area of pain management. There's a couple of drugs that I don't know how you guys feel about this, but I think ever since tramadol fell out of favor, gabapentin became like its instant replacement.
Ooh.
And I'm like, well, what's the evidence for gabapentin? Especially for OA pain. I personally don't think it works great, but that's what every GP is putting the dog on
Oh
gabapentin
yeah,
for their OA.
yeah.
And I think, those are the ones that end up getting ketamine because the pain is not well managed. Um, but,
Yeah.
and I,
Gabapentin is the new tramadol for sure.
yeah,
People dispense it like candy, right? They just
yes. Yes. And
give it
for the older
gabapentin.
dogs, a lot of these older dogs, they get knocked out on gabapentin. They're walking worse than they were before
Yeah,
gabapentin because they're ataxic. So, yeah, it's not a drug that I reach for OA management. The other one that I would love, that I suspect I think could have good utility, is acetaminophen. I think that's a drug that's been underutilized in veterinary medicine for pain management, but we don't have that. There was a one paper that was acetaminophen with codeine.
yeah,
Was not very efficacious. I don't think oral opioids are efficacious anyway, but it'd be nice to see more studies to see if that might be an option for an
yeah,
oral analgesic. I certainly have used it for patients that can't tolerate an NSAID, like let's say a patient that has a renal contraindication and liver function is normal, then we'll reach for acetaminophen.
yeah.
But yeah, those
Yeah,
those are those
they
are
do the same.
I hear a rumor there may be more evidence for acetaminophen coming out soon. I was asking questions about acetaminophen because it is a total deficit of knowledge for me, because
yeah,
where I trained we weren't using it, and then finished training, and then acetaminophen kind of took off a little bit and a lot of those residents started disseminating, and so I think it became back in vogue.
yeah.
And so it's just like a big knowledge gap. And someone asked me a question, so I was asking around, and then one of my colleagues said they're working on a review paper of acetaminophen in dogs. So
Oh,
I'm not sure
great.
what the ETA on that is, but
Okay.
fingers
Hopefully
crossed.
a publication out soon. Good.
Yeah,
Yeah. Yeah.
That's cool. That's cool.
Yeah. I'll tell you what I reach for more for my that does have evidence that I think is an underutilized, maybe because it had a bad stigma when it first came out, as cannabinoids. There's a wealth of evidence for both anti-inflammatory and even neuropathic pain management for cannabinoids. And in particular, Elivet, they've had multiple studies out of Cornell, and that's the drug that I reach for if I can't use an NSAID. NSAID would be the first thing that I would use if I can. But if there's a contraindication, did my sound?
No, you're fine.
oh, you're so good.
Oh,
Yeah, you're
okay.
so good.
The sound sounds different for me since my AirPod dropped out. But we treat a large population of our patients are senior or geriatric, and I definitely shy away from the NSAIDs in my older patients, but we need anti-inflammatory pain management. And I find the cannabinoids are really effective for getting that anti-inflammatory effect with, I would say some side effects, but not nearly as large as the side effects we see with gabapentin in the older
Yeah,
population.
yeah.
Yeah.
Speaking of anti-inflammatories, kind of not anti-inflammatories, what are your thoughts? Just because this is not an area I have a ton of experience with, and people were not fans when it first came out, was like Galliprant and Grappaprant. Like, what do you like? I'd heard, to me, the science suggests it would be great for chronic pain. I heard clinically that wasn't actually true, and it seemed better for acute pain. It's theoretically this great drug because maybe we can use it in those kidney and liver patients, or patients who do see side effects with NSAIDs. But yeah, what are your thoughts?
I'll tell you a story on that. When Galliprant first came out, I was very excited because, again,
Yeah,
big population of my patients are senior, and that seemed to be like, oh, this is just only an EP4 receptor antagonist. You're just much safer drug. So I had this, I'll never forget, it was a Maltese. It actually had MPLs, and it also had a cruciate tear. Dog was doing great on Rimadyl, but it was an older dog. It had cardiac disease too. So, it was just like, I felt like, oh, this could be kind of a frail patient, don't want to. Anyway, I called up the owner and said, this great new drug is on board. I'd like to switch from the Rimadyl to the Galliprant. And like, I'll tell you, about a month later, that lady called me up, like yelling at me. She's like, you ruined my dog. My dog was doing so great. And then you put it on this shit drug. And now my dog's limping again. And like, I just want it back on the Rimadyl. And I was like, wow. Oh my gosh. But that story is like, I mean, not that severe, but that's been my experience with Galliprant. Yeah. It doesn't work as well as your traditional nonsteroidals. And, the other thing, I think, to be fair, if you're going to be a true scientist about it, if you read about the drug, it'll say right on the label is contraindicated for renal disease and liver disease. So you shouldn't be using it in those patients anyway. And that's what I see veterinarians. The patient will come to me on Galliprant because they have chronic renal disease. And I'm like, well, you shouldn't be on Galliprant.
Yeah. Yeah.
And my theory for why it's less efficacious is because it is such a narrow target. It's your EP4 receptor antagonist for PGE2. And osteoarthritic pain is a lot more complex than that. You need a multimodal approach. And it makes sense to me that it's just not enough. So I think, if I have a patient, I don't prescribe it anymore. But if a patient comes to me, they're on Galliprant and they're happy with it, I'll keep them on. Fine. Okay. If they're well controlled, that's fine. But it makes a lot of sense to me. The patient's pain is not as well regulated on Galliprant compared to your COX-2 inhibitors. Yeah, for that reason, and also that I personally don't reach for it when there is a contraindication.
Yeah, for sure.
I wouldn't use that drug anyway.
Yeah.
So yeah, I stopped. I was very excited when it first came out, and then my patients were very disappointed with the results, and so I really, if you're on it and you like it, fine. Otherwise, I'm not using it.
No, I've never gotten an opinion on someone who's gotten to see patients for like a lot of follow-up on the drug. So my patients would only ever be on it short term, like the post-op ones. And so it's nice to get, someone who's seen a little bit more of the long-term kind of patients on it. So it's nice.
And that's interesting. I hadn't heard it that it's better for acute pain management. That's not the type of pain I manage, so I wouldn't know.
Yeah, that was what someone had told me about their experience with it because, I say this is an option, but like, we didn't stock it. And so it was always something I could tell, the clinicians I was working with for their patients. But then, we didn't have an ability to send it home with an owner to have that follow-up. So I would always ask RDVMs in the area about their experience just to try and like improve my knowledge about it.
Yeah.
So now probably we need to get to the hot topic.
Oh, I knew it was coming.
So what do you think about, a lot of veterinarians have been probably overprescribing this anti-NGF drugs like Librella and Solensia and whatnot. And so now we have more evidence of the side effects associated with them. Some of them are, from spanning from, most musculoskeletal issues to like cognitive dysfunction and stuff like that.
Yeah.
Like, what's your thought on that? Like, do they have a space in what you normally do, or is it patients that the GPs are trying not to ship to rehab? Where those patients would need somebody like you guys, but either they don't have an access to you, or they simply don't even have an idea that you even exist.
That's probably the case. Yeah.
And then
I'll tell you. I'm sorry, go ahead.
I don't know if they just put them on these drugs and, hope for the best, or I don't know what. Yeah. I've seen like clinics that like everything that was limping, they would just get Librella.
Librella, that's right. That's right. I think there's been quite an evolution since the drug came out. In our hand, we always confirmed OA. Of course, similar to Galliprant, we were very excited to use it. We used right away when the drug came out. Actually, we had a list of patients we wrote down. I'm like, these are who we want to try it on. Because they had advanced OA and we were managing them, but we thought, wow, this drug is going to be such a wonderful tool to improve their pain management. Since then, I would say even before things were out in the public, within the rehab community, we were starting to share with each other. First adverse side effects we saw was neurologic decline, acute neurologic decline, especially in our senior patients. And then it was sometime after that that it started to come out in Facebook and other forums and things like that. And then, of course, last year we had that paper come out in Frontiers. I thought it was well-written paper by other specialists. I did have a case of rapidly progressive osteoarthritis. We had it documented before the start of Librella. And I mean, it can't be anything else. I think that the biggest knowledge gap that was not shared with general practitioners is that nerve growth factor, I think the story, at least that we heard, was nerve growth factor plays an essential role during development for the development of the nervous system. But then in adult states, it's only negative. It's like, hyperalgesic states, and particularly regulated in patients with OA. But that's not the full story. And of course, it's not the full story for any growth factor. And we know that in adult states, nerve growth factor plays an essential role for maintenance of the nervous system. So we know for peripheral nerve function, also for repair of nerves. So if you think about your senior patient in particular has degenerating nerves, that nerve growth factor would play an essential role. Also, we know it's important in angiogenesis. It's important in tissue healing, particularly corneal epithelial tissue healing. So it has a constitutive role in adult states. And I think that's really the gap in knowledge that I don't think was shared. And I don't think it was from a lack of that knowledge, because it seems that has been studied. It just wasn't shared. And I do know the patients that come to me now is because they received a series of Librella injections and now they're not doing well. So then they come to me. And then what do we do? Do we keep them on Librella and I'm like, okay, well, first thing we do is we take them off Librella. But yeah, and so veterinarians are still using it. Sadly, I think there are still many veterinarians who are not confirming a diagnosis of OA and using Librella. I will say, in fairness, that I have had patients that came to us that had been receiving Librella and they thought it made a huge difference. They weren't experiencing side effects from it, but they wanted to come to us for strengthening or other additional things. I've seen so many negative side effects. My intuition wants to say take them off, even if you're not seeing side effects, just because I'm worried for them. The longer they're on it, that we might see some ill side effects. But to be fair, I think we need to learn more about the drug. In particular, I think patient selection is really, really important. I will say that the most common patient that I think Librella has been prescribed to is your older arthritic patient. And I worry that that's not great patient selection, because the older patient is more frail and has other comorbidities. And I think those are the ones that are particularly at risk for adverse side effects from a NGF monoclonal antibody. For me, what would consider it actually would be in the younger patient with maybe a severe elbow dysplasia, or it's a straightforward OA case, and they don't have any other comorbidities. They're not otherwise sick. They have no neurologic disorders. Then I think it could be a drug that would work very well for them. The worry in that case would be what's the long-term side effects of an anti-NGF growth factor. But I don't use it in my complicated cases. I don't use it in the frail patient. Certainly with any neurologic disease, I would not reach for it. If you read, we were told that the rapidly progressive osteoarthritis was a human condition. This is not a canine thing. But if you look at the human data, it's pretty clear why it was not FDA approved for humans. And it was because of the severe adverse effects. And here we are, the same types of things are being reported now that it's been widely used. So part of me either need like a big black label warning saying like, this is who you don't ever use it on, or take it off the market, because I just worry that it is continuing to be misused, unfortunately.
Yeah. Yeah, and yeah, I've seen a lot of that. Unfortunately, it's kind of sad. I think that there is an issue with you know the misinformation that's out there, right? Like we, I think as a profession, we do a really bad job at keeping up with CEs, right? And unfortunately, I think that the fact that you can pick which CEs you go to, I think I strongly believe it's an issue. Like I think
Oh,
like
that's
you
an
have the
interesting
2
point.
hours of mandated opioid CE, right? Like in some states you do. I think there should be 2 hours of anesthesia mandated CE, 2 hours of cardiology mandated CE, 2 hours of internal medicine. I
Especially if
think
that's what you do in your clinic, right? Like if you are anesthetizing patients, you're doing, things. Yeah, I hadn't thought
versus
about
like
that, but I agree. Yeah,
you may spend 10 hours in, I don't know, some random stuff about,
like about
you know,
growing your business.
yeah, learning. Yeah, and that's part of it. That's fine, but like it cannot be,
The
the
only thing.
sole source of your CE, right? Like the fact that you can spend 20 hours on one single topic when you're not a specialist, I think that that's a little bit of an
The other
issue.
thing I noticed too, because I was just at VMX, the most highly attended CEs are the ones where they provide free food, which are always sponsored. And of course,
Yep.
there's a degree of bias there. So, maybe you should be required to do non sponsored CEs so you get, little
Yep.
less. Yeah,
Yeah. And
it's a really
sometimes,
good
when
point.
they sponsor those, some of the people that speak are not actually experts, right?
Correct. Yes. Yeah. I mean,
Those
sometimes they're
are,
great. Like I've been to sponsored lectures where it's a university DVM who's, I would say, actually very unbiased, and I think we've all been to great sponsored lectures that I think is very, very informative. But then there's the ones where they're actually an employee of the company,
yep.
and they're not even DVMs, and they're giving CE to veterinarians is very biased. I think, yeah, you can see that the full spectrum of that possibility.
Yep, it's scary. And then there is the race approval thing, right? Where they say it's race approved, but in reality, nobody actually checks who that person worked for, who's like, what the connection is, how much money they get paid, if they get to the free flights and the free hotel, and like, you know, double your pay for a sponsor. You know what I mean? Like that's
Yeah.
you're definitely not gonna shit on that drug. You know what I mean? So
No,
like
that's right.
Yeah. Yeah.
it's, I don't know, I have a lot of issues with that stuff, and like
Yeah.
actually getting
Well,
proper.
and I think what I was thinking, that the paper that was published, these were obviously these are specialists who are not involved with Zoetis that are publishing this, and I think that's really what we should do as specialists is speak to each other, publish, learn from each other, and then disseminate that information. Because, for example, I was at VMX, and I do feel that's my role, is it because they're not going to be reading the publications, and so I see that as our role as specialists when we speak, is to educate the general practitioner about what's the latest information we have on this topic. What can we teach you so you don't have to read the paper? We'll summarize it for you and give you the key findings.
Yeah.
But I think that I think majority of your general veterinarians are getting information from the conferences that they attend. I don't know how many of them are reading journal articles.
Oh, nobody.
No.
And unfortunately, the other side of things is that like they don't really have time, right? Like when they,
I would say that's, yeah.
if
For me, I mean, I
people,
read because we cover it in Journal Club, so I have to read it.
yeah, and some of them don't even have access to journal, right? That's the other big problem,
Oh,
right? Like if
that's a
you
bit.
look
I
at
mean,
the,
even for AMC, we lost access to some journals. Yeah, it's hopefully a lot of journals have now moved to open access, which is great because yeah, that's a big issue. Is like I think VCOT is still not open, and there's some that's the Veterinary Compendium of Orthopedic Trauma. You may not know that one, but there's some really, I would say, reputable journals that are not publishing on open access. So a
yeah,
very big population doesn't have access.
yeah, which is an issue, right? Like those subscriptions are extremely expensive. if you want to buy an article, I think it ranges from like 20 to 50, sometimes even $70, right? Like, which is insane, right? Like, for somebody that's like 1 or 2 days of groceries, right?
Yeah.
And that's to pay for one article, which is insane.
Yeah. Yes. So
It's
it's not
not.
happening.
Yeah, it's not happening. And so I can't really blame them for not reading. I can't really blame them. So, I get it, but we need to do a better job. Like, I think even us as specialists to, like, disseminate that information, right? Like,
Yeah.
and have a bigger reach out there. And it's not against any drug. I think every drug has its place, right? Like, Librella has its place in some patients. Galliprant has its place in some patients for sure, and so does gabapentin. But um, you need to be aware of what the risks are, and you need to present the risks to the owners, and if they're fine with it, it's fine. It's just you need to be aware of it, though. You can be totally blindsided, and
Yeah. No, that's exactly right. I distinctly remember when I learned about the side effects of Librella. I had clients in making appointments. The presenting complaint was wants to start Librella. And I had open conversations with them. I said, these are the risks. And some of them, if they wanted to try it, was like the big hype. And I think people, they're hoping to see that miracle change. And yeah, I think that's right. I think our role is to educate, to present the potential adverse effects, and client hopefully makes an educated decision based on that information.
in some patients they do see an improvement. I've
Oh,
heard
of
a few
course.
of
Yeah.
stories out there that say the dog's completely changed.
Yeah.
Yeah. Yeah.
And probably, I mean, the other to play devil's advocate here, right? Or maybe we do see, or at least you guys see more of the ones that didn't go well because that's when they get referred.
No, exactly. We have, I would say, a more biased population. Definitely. We see the more complicated cases. That's why they come to us in a tertiary institution.
So I don't know what
Absolutely.
the percentage is of how many of them get those kind of side effects, but like, you know, I see clinics prescribe it left and right, and you know, I don't know how many side effects they see, but if every clinic is doing that, that means that probably there is very few of them that actually do have the side effects. But when there is side effects, they're really bad, right?
That's
So
right.
yeah, it's just sad when people weren't educated on the potential side effects, right? That's
Yeah.
that. I think where they now that we got at the end of the hour. So we always ask this question to our guests: what's your favorite hot dog?
I don't eat hot dogs. I'm vegetarian.
You don't like a vegetarian hot dog?
No, it's gross.
Wow.
Oh my God, Rob.
That, I mean, it's okay. Like, everyone has their own thing. And I think with
That's
hot
funny.
dogs, I am a like huge hot dog lover and fan. In fact, I wore my hat that I recently
Oh,
got. It said,
well,
"It's a bad
have
day
you
to be
been
a
to the
hot dog."
Nathan's hot dog?
I've had
That's,
Nathan's, but I've never. I lived in New Jersey, and I never made it out to Nathan's. Like,
oh, okay.
I did my internship in Red Bank.
Oh,
Um,
nice.
so I was in Jersey for a year. I never made it out to Nathan's.
Oh,
Wow.
That's
I
like
mean,
a
I
big.
think it's really fun to watch the hot dog eating
Oh
contest,
my god! Of course.
I mean, they're like, it's like professional thing. Now, if you really want to know my answer to that, probably the closest thing is Trader Joe's makes a really yummy vegetarian chorizo, and I love that.
Oh.
Okay.
I'm
Hmm.
always my brother's a vegetarian and I obviously love hot dogs. So I'm always looking to try and like bring something that's not just like the like some of the grocery options are like honestly terrible and just like
Yeah.
so sad.
See, I,
But
as a
like
vegetarian, I don't like the imitation things
yeah.
because, I'd rather have, there's like wonderful vegetarian meals that are just
Yeah.
delicious. Like they
Oh
don't
yeah.
need to taste like a hot dog.
Yes.
But that I will say that chorizo is really yummy.
Okay.
So if you
All
could
right.
bring that for
I
your
need to
brother.
try it.
Well, that's good enough. Thanks.
Yeah.
I need to try that. Well, thank you so much, guys, for being here. Thank you so much for joining us tonight. I guess we'll see you next time.
All right.
Thanks,
Thank you
guys.
so much for having me.
Thank you. Bye.